Yes, we are live now.
Sure, ma'am.
Good evening, everyone. This is Ankana, the Ascent moderator from IGCP Group. I welcome all the delegates across the country in today's session. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today. On the eve of World Brain Tumor Day, we will take a look on today's topic that is beyond the obvious pediatric brain tumor presenting as a stroke. Hence, without any further delay, I'm taking this opportunity to today welcome today's Master Doctor, none other than Dr. Pratik Kumar Panda sir. Sir is the Associate Professor of Pediatric Neurology Division at AIMS, Rishikesh. Now, I'd like to hand over the session to you, sir. Kindly proceed with your topic. Over to you.
Thank you. Good evening, all the delegates and all the viewers today who are present. And I also thank IJCP Group for giving me this opportunity on the eve of World Brain Tumor Day. So I am going to present today a rare case. Since this is a brain tumor day, so I am going to present a case of brain tumor that's in a child, and that presented to us as a stroke or arterial ischemic stroke. So this is a case of a 12-year-old boy who is a resident of Bijnor, Uttar Pradesh, and who presented to us with complaints of weakness of the left side of the body for 10 days and also headache for 10 days. So, since there is weakness of the left side of the body, we initially thought of any stress occupying lesion or any arterial ischemic stroke or any demyelination. Since this is the some hemiparesis kind of thing, but when we went into the history, so they told that the weakness was acute onset. That's something important to concern, and there was clumsiness while walking. The patient, whenever after the disease onset started to walk, there was clumsiness. Suddenly, it also progressed to an extent that he was unable to bear the weight on his left leg. So the weakness was progressively worsening. It was a start as a acute onset, but later it progressively worsened and also involved the left upper limb. Started from the left lower limb and then involved the left upper limb also. So it progressed in the term of extent as well as in the term of severity. But the progression, but there was weakness was more in the distal part of the extremities, and the weakness was more in the edge when presented to us. It was more involving the upper limb as compared to the lower limb, but it reached to a position. The boy, he has a difficulty turning in bed and also sit up from the supine position. So a little bit also probably involved the trunk weakness. So as a result of this, the person or the boy or the became non-ambulatory. He was not able to completely bear the weight. For and obviously he was dependent for his activities of daily living on the immediate caregivers. But to note something important is that there was no facial deviation to the right side, and also there are no facial elevation to the left side suggestive of either upper motor neuron or lower motor neuron kind of facial palsy. There was also no history of difficulty in closing eyes, so probably facial involvement was not there, but definitely there is upper limb lower limb involvement, and trunk involvement to some extent probably was there, and that was for 10 days only. And more importantly, there was a acute onset headache. It was present every day. It was not present only at the beginning. It was mainly in frontotemporal in location. Initially, it was a moderate in intensity, but now as it progressed, it was present throughout the day, continuous. But there was no nausea, no vomiting, no photophobia, no phonophobia, no aura, and no history of similar episodes in the past or in the family members. There was also no history of seizures, no poor sensorium. The patient has completely normal sensorium, no behavioral abnormalities, no vomiting. There was no history of vertigo also, no history of trauma, no history of fever, no history of any rash, and no joint pain, no history of any recent vaccination, no history of any respiratory distress, bluish discoloration of the lips, suggestive of any comorbid cardiac or respiratory illness, no history of any easy fatigability, blood transfusions, or bleeding manifestations. So there is no significant hematological involvement also. Now going a little bit into birth and developmental history, the baby was or the boy was a term born, appropriate for gestational age, normal vaginal delivery, and the birth weight was 2.7 kg. There was smooth perinatal transition, no antenatal or perinatal adverse events, and the boy till the onset of this illness attained all developmental milestones in a proper manner, and the boy was studying in 7th standard with good scholastic performance. The boy was also immunized appropriately as per the national immunization schedule. The boy was born second out of a non-consanguineous marriage. There's no family history of migraine or brain tumor or any stroke or any kind of things. No neurological illness. The family members as such. Then we went into the examination. As at the time of presentation to us, the boy was conscious, oriented to time, place, and person, and the speech was not that much affected. So pallor was no pallor, no jaundice or icterus, no cyanosis, no clubbing, no lymphadenopathy, no edema. Heart rate was 90 per minute with regular pulses and no radial delay, no radiofemoral delay. In the all lateral walls are well palpable. Respiratory rate was 18 per minute and thoracoabdominal in nature. All the central pulses and peripheral pulses they were well palpable. Blood pressure was 110 by 68 millimeter of mercury, and oxygen saturation was 98% on the room air. Anthropometry shows weight of 30 kilogram when Z score of weight for age of Z score was minus 1.1. Height was 153 centimeter and height for age Z score was zero point 0.6. And weight for age, height for age, they are all within the normal limits, and the boy's anthropometry was preserved. Most importantly, what we could observe was there was a neurocutaneous marker, and this was present mainly on the left side. It was hardly touching this, hardly crossing this midline, mainly on the left side, and starting from the umbilicus and extending up to the lower limb and mainly up to the end of the thigh, but also sometimes onto the leg and also even up to the foot. More present on the this anterior aspect, and then also the lateral aspect of the this foot and up to the leg, also somewhat this extending onto the buttock also, and also back of the thigh. This was a grayish color, or this is a kind of a coffee gray color hyperpigmented spot, and what is present from the birth. So it was a neurocutaneous marker, and large capillars, large melanocytic nevus, we can call it as large melanocytic nevus. The boy was right-handed, and higher mental function was, as I have already told, this boy was conscious, oriented to time, present person. Although history-wise they didn't tell anything about the facial palsy, but when we examined closely, we found out that there are some upper motor neuron type of facial palsy. Left side was there, so there was no difficulty closing in the eyes, but there was some deviation in the angle of the face. Rest of the examinations of cranial nerves are normal. Also, we examined fundus, which was normal. Motor examination, bulk was normal, bilateral symmetrical, but we can observe that there was hypotonia in the left upper and lower limbs. And then we did the MRC staging, that the muscle MRC, modified research council muscle staging. The shoulder flexion, extension, abduction, adduction, internal rotation, external rotation, all were normal on the right side, but left side it was 3 by 5. Elbow flexion and extension, again left side was affected, 3 by 5 power only. And this was more profound weakness at wrist, all flexion, extension, ulnar and radial deviation, 2 by 5 only. Then metacarpophalangeal joints and interphalangeal joints, flexion extension was also 2 by 5. And the palmar dorsal interossi also 2 by 5. Similarly, in the hip, flexion, extension, abduction, adduction, internal rotation, and external rotation, that was more affected on the lower side. Right side was completely normal, 3 by 5. Knee flexion and extension was also affected on the left side. It was 3 by 5. Ankle, plantar, and dorsiflexion, it was 2 by 5. So it showed that dorsal and at this left side, upper and lower limb both are affected. Distal weakness more than proximal, wrist onwards and this ankle onwards, the weakness was more prominent. The gait, it was sort of clear-cut hemiparetic circumductive gait. Sensory system examination, including cortical sensations, they were normal. There is no signs of meningeal irritation or cerebellar signs. Systemic examination and the chest movements were equal on both sides. Bilateral air entry was also equal, and there were no added sounds. The cardiovascular examination, S1 and S2 were completely normal, and there were no obvious added sounds or murmurs. Abdomen was also non-tender, no organomegaly, and bowel sound was present. So when we combine the database and the summarizing the case, there was a 12-year-old boy, left-sided hemiparesis, acute onset, but it was progressed slowly over the 7 days. There's non-progressive headache, and there is giant melanocytic nevus over the left side of the body, and there is also left upper motor neuron facial palsy. So the differential diagnosis are the first possibility, we kept a vascular possibility, stroke, whether it is we kept hemorrhagic stroke or intracranial hemorrhage rather than a arterial ischemic stroke, more likely. Since it was acute onset, there was associated with headache, and there was also ipsilateral upper motor neuron difacial palsy. But the points against were there was no altered sensorium or seizures, there was no nausea, vomiting. And for arterial ischemic stroke, it was that it was progressed only after 3 4 days. That was something which was against, and also there was associated headache. Then we also kept a possibility of cerebral venous sinus thrombosis. So we since there is acute onset focal neurological deficit along with headache, but the points against where there is no blurring of vision, no vomiting or poor sensorium, no papilledema, and there is no underlying prothrombotic condition or similar prothrombotic state. Then obviously we kept a possibility of intracranial space occupying lesions like infective brain abscess, which could be bacterial, tubercular, fungal, because there was headache and there was this focal deficit. But the points against whether was acute onset, although it will progressed over it. There was no fever and no obvious signs of raised ICP at the time of presentation, apart from headache. Obviously, we kept a lower down possibility of brain tumor or neoplasm because there was a neurocutaneous marker was there, headache was also there, and there was focal deficit was also there. But the acute onset, mimicking a vascular stroke, that was a different thing here. And there was obviously no signs of raised ICP. Then we went on to this gadolinium enhanced MRI brain, which showed a lesion over say, this pontocerebellar angle over the right side, we can left side and expanding. So we see that there is a significant large enlarging expansile lesion, which is also somewhat involving the brain parenchyma, cerebellum, nearby brainstem, and causing large amount of weakness. So there was no. We found out that there was also a lesion involving this thalamo and this gangliocapsular region, and then we went ahead with this diffusion weight imaging and this ADC imaging. It showed some this diffusion restriction and facilitation, showing a kind of heterogeneous kind of thing. So this tumor, this was we also applied, since we are thinking of more in the line of tumor. So we went ahead with also with this magnetic resonance spectroscopy over the lesion was present bilateral, although mainly that is on the this acute change. There was a hemorrhage or anything. So this was more on the right side. We can see also the lesion was on the left side. So we showed a choline peak, but there was no inverted this such this lactate peak was not that much significantly seen. So with this, and there are also other the changes. We can see that there are some subependymal tumors and other things are also there. But with these lesions, with these, we also went ahead, since we are thinking of stroke, magnetic resonance angiography. So it showed it was completely normal. Other investigations, hemogram, this complete blood count is totally normal, and the sepsis markers were also negative, CRP and procalcitonin, and this coagulopathy, PT, INR, and APTT, as well as platelets are normal. The liver function test and renal function tests were also within normal limits. We also went ahead and did a CSF examination, which showed 5 cells, 100% monomorphs. CSF sugar was 122, protein was 91, and it was negative for this India ink stain and KOH, suggesting no fungal involvement. Then CSF culture and sensitivity was also sterile. CSF CB0 was also negative, and showing it was negative for TB. CSF cytopathological examination was also negative for malignancy. Blood culture was also sterile. Then we were this. Then we want what was this lesion which is occurring, and this what are these things? Whether it is associated with any uh, tumor or in malignancy, or what was this was a nodular heterotopia or whatever it is, we didn't know. So we went ahead and we did this next generation sequencing, whole exome sequencing. So as we have seen, there are a lot of periventricular nodular heterotopias, and so we found out also a gene, FLNA gene mutation, that is a point mutation we find out. So this FLNA gene, which was associated with periventricular nodular heterotopia, X-linked dominant, and this homozygous gene. So we thought that it might be associated with periventricular nodular heterotopia with this, and probably this predisposed towards having this tumor. So this X-linked dominant form of this benign periventricular nodular heterotopia, this mutations in the FLNA encoding filamin A gene, this is a major cause of most of these boys. Since this is a boy, most of the boys they actually expire in the prenatal and the neonatal period, but few males they live with this condition have been reported in literature. Two were the adult males with benign this periventricular nodular heterotopia. and both have normal cognitive development. One did not manifest any seizure until he died at the age of 57. So this missense and this distal truncating germline mutations, they are compatible with survival in males, as occurred in our case. Somatic mosaicism in patients with truncating mutations may also attenuate the phenotype and be observed in those surviving. So that could be the case in our. That's why our boy is surviving, sin, despite having a X-linked dominant inheritance. So finally, we find out that it is a neurocutaneous syndrome, giant melanocytic nevus. Although there are large number of periventricular nodular heterotropias, and along with that there was a neoplasm, which is more on the right side, causing hemoparalysis with some changes occurring hemorrhage and calcification within that. So probably a glioma. So with that, we went ahead and we called our neurosurgery team. So they didn't touch the periventricular nodular heterotopia, but they operated upon the tumor part. Mainly, they took a biopsy, and ultimately it was found out to be a glioma. So, and subsequently, the child received some chemotherapy also, and the area was resected. Now the child is doing well, and so although there is some deficit is still there. So, the take home message was that brain neoplasms can present as a stroke, and due to hemorrhage, as we see in this case, there are some hemorrhage within the brain tumor, or if there is an acute increase in size of the lesion. In a child with neurocutaneous marker presenting with acute onset focal neurological deficit, you should consider a possibility of brain neoplasm with a hemorrhage or something like that inside. So that might be the take-home message from my side, and that's all from my side. We are that's the case of giant melanocytic nevus with a genetic proven periventricular nodular heterotopia with some glioma and hemorrhage within, which is presented as a stroke. So that's all from my side, and now I am stopping the slide sharing so that I can take the questions.
Thank you so much, sir, for this beautiful short PPT that you have elaborated and share your experience. So we have received a few questions from our participating doctors. With all your permission, can I put them across?
Sure, ma'am.
Okay. First question is, how does diffusion weighted MRI help differentiate between tumor related edema and infarction?
Yes. We didn't have actually know what was the nature of the lesion, since there were a lot of periventricular nodular heterotopias, and there were this lesion which is on the right side. Along with that, this diffusion weight. If you see carefully, look at the diffusion weight imaging. There was restriction, diffusion restriction, and outside that there was diffusion facilitation. So also we took into account the susceptibility weight imaging. We saw that it was a bleed. So whenever there is a diffusion restriction or diffusion facilitation, so diffusion restriction shows that there is some infection or some lesion has occurred inside the tumor, and then whenever there is a hemorrhage or anything outside the hemorrhage, there is usually some edema. And if it is a acutely increasing tumor, like a brain tumor, glioma, high grade glioma, unlike the periventricular nodular heterotopias, so there will be some edema and there will be some inside necrosis also. This edema and necrosis, they sometimes show diffusion restriction. So in their case, there's some diffusion restriction was also there. So whenever we are making a MRI report or anything like that, we take into account the susceptibility weight imaging, diffusion weight imaging, then magnetic resonance spectroscopy, and this T1, T2 weight imaging, then this gadolinium enhanced imaging. Taking into account all these things, we have to find out whether it is a demyelination, whether it is a brain abscess, whether it is intracranial hemorrhage, or it is a secondary bleed, secondary intracranial hemorrhage within a tumor. In our case, it was a secondary intracranial hemorrhage within a tumor. Thank you.
Okay. Moving to the next question. Does initial stroke like presentation correlate with worse outcomes in pediatric brain tumor patients?
So the most important thing is that when a tumor is presenting like a stroke, one thing is that it probably something, either it is acutely increasing in size or some hemorrhage or some acute event has occurred. It has compressed some vessel and caused a kind of stroke. So it shows that it is a high grade tumor. So prognosis of a brain tumor depends on the grade. Definitely, if it is presenting with hemorrhage or anything like that, then it is some adding up to the comorbidity. But as such, presence of a hemorrhage does not always indicate prognosis poor. Uh, but definitely the tumor grade in our grade it was a whenever we went ahead with the histopathology, it was grade 2 or grade 3. So the child is surviving. It depends on a lot of things nowadays. Whenever we are going to histopathology, we are doing also a lot of gene MIB index, and there's a lot of genes P53. So prognosis not only simply depends on whether the hemorrhage it depends on how rapidly and we identify in time and we treat them. That is the thing. It's a multifactorial thing.
Okay. Moving to the last question of today's session, is thrombosis or anticoagulation ever indicated in such cases or contraindicated?
Yes, mainly in this case, there was some hemorrhage inside the tumor. So definitely we'll not go ahead with thrombolysis or anything. Whenever there is a pediatric atrial ischemic stroke, we can do thrombolysis. Recently also we did thrombolysis in one case, but there was not tumor-like cases. And arterial ischemic stroke, in hemorrhagic stroke, definitely thrombolysis or anything is not contraindicated. And in hemorrhages, what we do is we do a magnetic resonance angiography and digital subtraction angiography to look for any vascular malformation, arteriovenous malformation, or any this cavernomatous malformation like this, and then we can do coiling, clipping, or any neuroradiological intervention to close this. But in arterial ischemic stroke, if you are suspecting of a embolic stroke, if it is a thrombotic stroke, then we can within the 3 to 4 hours they come. Then case to case basis, although in pediatrics it is not recommended like adults, we can do thrombolysis. Thank you.
Okay, sir. Thank you so much, sir, for your expert opinion that you have shared. And I would also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable time and for being with us at the platform and sharing such valuable insights. Thank you so
Th-
much. With
Thank you.
all your permission, can we end the live here?
Sure, ma'am. Sure, ma'am.
Okay, sir. Thank you, sir.